TAVR is an extraordinary success story. One of the issues that we have not had a good handle on until now is cost analysis. We have a first of its kind economic analysis of TAVR for patients at high risk of surgery. And I'm with Matthew Reynolds, MD of Lahey Hospital and Medical Center in Burlington, and also Harvard Clinical Research Institute, where you're the Director of Economics and Quality of Life Research. Okay, first off, how was the study conducted that you presented here at TCT?
Sure, so we took patients from a completed clinical trial, which was very much in the news earlier this year. So the CoreValve US High Risk pivotal trial, randomized trial in the as-treated population, 747 patients who were randomized to either TAVR with the CoreValve system or surgery. And importantly from that trial, 5% absolute mortality difference at 1 year was reported. So what we presented yesterday was the health economic analysis based on that trial population. And that analysis involved both an in-depth review of survival, quality of life, resource use, and hospital billing data through the first 12 months, and then projections. In order to get the cost effectiveness equation correct, you have to project over the patient's lifetime. So we made survival projections and cost projections for both study groups.
Now, short term, it was a little more expensive, but long term, the story was different. How did it figure out in the end?
So there's an upfront technology cost. So TAVR is a beneficial new technology, and usually with beneficial new technologies, there's some upfront technology cost. There are cost offsets. So one of the things that TAVR does is it allows patients to recover more quickly. And so they get out of the hospital much faster than after surgery. In this trial population, the reduction length of stay was about 4 to 5 days. And then when they leave the hospital, they're more likely to go home than they are to, say, a short-term rehab facility. So in the trial population, 23% of the TAVR patients were discharged to rehab, whereas over 40% of the surgical patients were discharged to rehab. So that makes up partly for the increased technology cost, but what you say is true. There was incremental cost to the TAVR strategy, about $11,000 per patient for the initial hospitalization. That shrinks to about $9,000 per patient at the end of a year because of that reduced rehab cost, that sort of thing. Over the patient's lifetime, one group survives longer than the other. So guess what? The group that survives longer accrues a little bit more medical costs as well.
Right.
So actually, from a lifetime perspective, we projected that costs would be higher with a TAVR strategy by a little bit under $14,000 per patient.
So were you happy with what you found?
We're certainly happy with that. So cost effectiveness analysis is an attempt to put incremental benefits in light of incremental costs, or vice versa.
And everybody wants to know what the costs are for today.
Everybody, well, it's important for hospitals to understand this for coverage and reimbursement policy. So that's why we take a careful look at this. So we're happy with the results in that these incremental benefits from this intervention, which were very important clinically, were achieved at an incremental cost, which we, not only we, but health, authorities in the health economics field consider, reasonable, or we would say that this is right in the range of high value therapy. So it doesn't have to be cost neutral. I was asked that yesterday to provide a good value.
Right.
Since it's good for patients, it's okay for it to cost a little bit more as long as that incremental cost is reasonable, which it was.
Anything else? I mean, where are we going in terms of, have you answered all the cost analysis questions you wanted to answer?
Well, no, we're not done by any stretch of the imagination here. First of all, this was a trial population, and that does introduce maybe some artificial conditions, and I think that some of the leaders in the TAVR field have pointed out over the last 24 hours that we really, we absolutely agree with this, we expect things to get better. Surgery is the old standard. We don't think surgical costs are going to come down a whole lot. But we do think costs will come down with TAVR, in particular because people will get more efficient at doing it. And we'll get the patients home even faster than they're getting them home now. We'll get fewer complications, that sort of thing. So we definitely expect to see things get better going forward, and that needs to be documented. We need to collect data from Medicare and from the TVT registry and show those trends in length of stay, for example, that we expect to see. And then we need to look at what happens in actually lower risk populations in this one as well. So the clinical trials of TAVR have been moving down the risk spectrum.
Exactly.
And we'll need to look at the health economics every step of the way.
It should be interesting, and congratulate you for getting this cost analysis done. This is a question that some people have been asking for some time.
Well, thank you very much.
And for CardioSource World News, we have a variety of stories coming out of TCT. Please check us out. I'm Executive Editor Rick McGuire.